may have some options. Okay, dyspnea. Dyspnea is a sense of breathlessness. It is a subjective feeling. Every person has the right to complain of being breathless. You may not judge them to be short of breath by any objective parameter, but they have the right to complain of feeling breathless if they'd like. So when you're talking with them on the phone and you have a patient who's complaining of being really short of breath and you're on the other end of the line and say, this person is not short of breath, they can't even stop talking to let me get a question in. The point is they can have dyspnea if they want, all right? They may not have shortness of breath, but they can complain of that. It is more associated with the work of breathing than really hypoxia, and it's because it's subjective, it's hard to quantitate or quantify. The degree of distress depends on how suddenly it appears. So for people who have had this complaint chronically, they're actually not in much distress. They might be quite calm about it. For the person who has a spontaneous pneumothorax and now has dyspnea, they'll be quite distressed by it, as you might imagine. So this is a list of causes. You can categorize them as sort of acute respiratory causes. Of course, asthma might present the first episode like this. I mentioned the pneumothorax. Chronic lung disease might present. You might have a person with a long time smoking history who's done relatively well, and then something triggers them, so now they have dyspnea. It could be neuromuscular disease. It could be infectious, like epiglottitis. That'd be a little hard to miss, though. In the context of that, a young child leaning forward drooling is a little different than any of the other scenarios. What about diagnostic testing? Of course, after you get a history and examine them, a chest x-ray may be valuable, looking for flattened diaphragms, looking for a spontaneous pneumo, as an example. If you have any history of tobacco abuse, spirometry might quantitate the level of pulmonary function that you have. Any risk for PE, think about imaging them to look for PE. Maybe the money's for the cardiac evaluation. Maybe this is a presentation for failure. And then thyroid and CBC may be appropriate, and stress testing if you think it is cardiac is the cause. Our treatment is aimed at what we find. Oxygen may not correct the dyspnea. It might correct hypoxia, but the dyspnea feeling may persist. There may be a role with anti-anxiety agents. Certainly after you've worked through this approach, and if people are stable physiologically, there may be a role for that. And then morphine may be used acutely, of course. Now, what about the chronic dyspnea patient? The majority of those have clues to diagnosis. This is not something that is sudden, and usually a great physician can just think through what it is. And so you can see from the listing that most of them will be clear. Deconditioning, of course, is one of those that we see with so many people with other chronic diseases. You know, bad knees, I can't walk, I've been gaining weight in that cycle. And many people have multiple causes. The diagnostic studies are similar to what I just mentioned. Sometimes just a pulse ox in the office will be helpful to reassure you that they are stable. And then the oximetry during exertion, or as we call it at our hospital, the oxygen saturation walk, is extremely helpful. You could probably do it in your office, but it's also done like by the pulmonary rehab people. It's basically measuring O2 sat, having the patient walk for 50 or 100 yards and seeing if their saturation holds or if it drops. And that will give you some clues to how vulnerable their pulmonary status is. So as I mentioned, many people have more than one etiology, and the history and physical will get you money about 70% of the time. So that's good.